Welcome to today's webinar, Children's Mental Health in the Aftermath of Disasters, Rebound and Recovery, a Florida State University response to Hurricane Michael, a collaboration with Save the Children. This webinar is brought to you by the Center for the Study and Promotion of Communities, Families, and Children. Disasters have the potential to cause short and long-term effects on the psychological functioning, emotional adjustment, health, and developmental trajectory of children. In this webinar, we will highlight Florida State University's response to Hurricane Michael, which struck the Florida Panhandle in October 2018. You will learn about the adjustment difficulties in children in the aftermath of a disaster and how to promote effective coping strategies to mitigate the impact of a disaster, as well as any associated bereavement and secondary stresses. Finally, we will underscore the need for state and local governments to include in disaster planning the mental health needs of children and their caregivers. Today's webinar will feature 5 speakers: Dr. James Clark, Dean and Professor, FSU College of Social Work; Ty Cole, Research Assistant, Center for the Study and Promotion of Communities, Families, and Children; Dr. Tisha Holmes, Assistant Professor, Department of Urban and Regional Planning; Savannah Smith, Program Associate, Center for the Study and Promotion of Communities, Families, and Children; and Ellen Pyakalkiewicz, Director, Center for the Study and Promotion of Communities, Families, and Children.
Hello, my name is Jim Clark, and I'm Dean and Professor at the College of Social Work at Florida State University. And it's my pleasure to talk a little bit today with you about how Florida State University College of Social Work got involved in the behavioral health disaster response to Hurricane Michael. It's important to realize just how devastating a natural disaster Hurricane Michael was for people in the Panhandle of Florida. Michael made landfall on October 10, 2018, west of Mexico Beach, Florida, and essentially wiped out Mexico Beach as it was a high-end Category 5 hurricane with wind speeds of about 156 miles per hour. Hurricane Michael was the strongest hurricane to ever hit the Florida Panhandle and one of the top devastating events to ever hit the mainland United States. The strongest winds were observed at Tyndall Air Force Base, where gusts were up to 139 miles per hour, and the storm surge of 8.5 feet hit the small town of Apalachicola, Florida. So we can tell right away from looking at these statistics that this hurricane devastated an important part of rural America, and that is an important fact for understanding the nature of our response and the kind of need that this part of the country experienced post-disaster. Our college was contacted to assist with the mental health recovery in the immediate aftermath of the hurricane. The Federal Emergency Management Agency contacted me and requested 88 trained social workers go into the region as soon as possible and to work in primarily school systems and other child congregate areas. And unfortunately had to respond to the federal government and say that there weren't 88 trained social workers available and that we did not have an adequate workforce in the region in terms of behavioral health. Not enough of them in the schools and not enough that could prevent or treat in an outpatient way or in vivo on school campuses. And part of the thing to understand about disasters like Hurricane Michael is that disasters highlight the absence of services that had been ongoing for many decades. What was interesting about this was the hurricane brought to the attention of the federal government, state and local government, number one, the importance of behavioral health interventions, and number two, the fact that there was not a workforce in the region that could provide those. And fortunately, we were able to think through what could be an alternate response in the face of those kinds of gaps. What were the psychosocial effects of Hurricane Michael in the region? Well, a very important fundamental fact was that 70% of the housing was destroyed, and over 60% of the child care centers were destroyed. Schools were destroyed. In fact, schools were rendered inoperative in certain parts of Bay County, requiring special shifts and doubling up of school days in very non-traditional, unpredictable ways, creating a lot of stress on the part of teachers, administrators, and students. Children lost people they loved. There were 59 deaths in the area, and there was immediately a 14% decrease in the student population, which triggered 600 school staff layoffs. So just at a time when resources were really needed the most, the economic base to fund those positions was destroyed. One fact that we discovered that was rather novel was the importance of large stands of timber all over the region, and that 95% of the timber in the region was destroyed, which was the major investment of many companies, but also many small farms and individual investors. Thousands and thousands of acres of timber were destroyed, and as we drove out into the region, we could literally see this in the major highways the closer we got, and certainly when we got onto the small rural roads, very tall pine trees and other rich timber snapped in half like matchsticks. The response for children was particularly severe. There were at least 2 emergency psychiatric evaluations performed per day, and many children were hospitalized as a result of that. From a trauma-informed standpoint, the difficulty that we saw happening was that while there were many, many tools available for preventing the escalation of behaviors that are natural in groups of children post-disaster, we didn't have the staff in the region to perform even simple de-escalations and timeouts and psychological first aid. So we were very happy to get a call from the organization Save the Children, which does wonderful post-disaster work around the world. And they reached out to us and asked for a partnership and helped fund us to do a program called Journey of Hope. Journey of Hope fits a lot of the criteria that we expect in post-disaster trauma-informed approaches. This one is a Journey of Hope. This intervention is really aimed at kids between the ages of 4 and 18 and is organized into 8 one-hour sessions that occur once a week. What is so important post-traumatic event is to give people, and especially children, the words they need to express their feelings, and to do that in a way that promotes social solidarity. So doing this in group work rather than in individual sessions was important for kids so that we could work with them in a lot of fun and novel ways to develop coping strategies through cooperative play, creative arts, and literacy. So we went to schools and summer camps and other child serving environments to do that in this partnership. As a result, in the summer and fall of 2019, our team was able to train 25 facilitators in Bay County in this intervention approach, which is significant because we were able to synergize the impacts relatively soon after the event. And then we were able to directly serve 80 caregivers in Bay, Leon, and Gadsden counties so they could be better equipped to work with and to support their own children and the children that they came in contact with after the disaster. More specifically, we were able to serve 53 students through this approach in Bay County and 155 in Gadsden counties. And we're still present in the region and still working because this disaster is going to take at least a decade to recover from. For example, 1 out of 6 kids are still in temporary housing. And by temporary housing, it can be everything from couch surfing to living out of a car to living in a shelter. Unfortunately, depression and mental health problems continue to go on the rise. And while we are present and working in the region, of course, the need is so much greater than the personnel available. Kids are so crucial to the future of our region and our state, and we're deeply committed toward continuing these kinds of trauma-informed approaches. Kids reported to us that they learned how to talk about their feelings, and they also learned something else important, that their peers were struggling with confusion and depression and anxiety. One example that really has been moving to me is the fact when severe thunderstorms are in the region, it serves as a trigger for those kids that lived through that Category 5 hurricane. So even beginning to talk about being afraid and being worried is extremely important. Not only understanding feelings, but learning how to use active coping approaches to dealing with those feelings has been a great outcome that kids have reported to us as a result of our interventions. We still are struggling over a year later. $1.9 billion have been earmarked in federal dollars for Hurricane Michael. There's been a wonderful response, and some of that is recorded in this infographic you're looking at. The problem has been, of course, that the flow of dollars has been uneven and delayed, and that has extended the stress levels for over a year post-hurricane, which has required and will require ongoing behavioral health interventions, even as claims are paid and funding flows into the region. And we have made a very strong case, the fact that behavioral health interventions are as important as any of these other types of claims. We're very thrilled with our partnership with Save the Children. It's going to be wrapping up at the end of 2019, but we've established a relationship with them that we very much value, and we've learned a lot from their disaster response approaches, and we're grateful that they approached us and for the partnership and for the funding. When I went into the region to visit Florida State University's Panama City campus, I was very much struck by the fact that community representatives came out as well from Bay County and asked us to become involved. You know, the stereotypes of rural community is being closed off and not willing to ask for help. The disaster certainly revealed that rural leaders were extremely interested in taking care of their kids, and they requested behavioral health resources from us. And I was really happy that we could participate in a robust way. We knew that taking care of children was very important for the whole region, especially since, as a prevention approach, the insult of major traumatic stress disorder on developing brains was at stake. And while we knew that 12% to 15% of people will typically develop serious stress illnesses long term, and including post-traumatic stress disorder, we knew that there was a tremendous opportunity to prevent that from happening, maybe for the first time in our history as a country, because of the efforts of so many federal and state agencies that are dedicated to behavioral health care, including SAMHSA and NIH. We have the technology and the science to really do significant psychosocial interventions. And that science can be marshaled and used in rural and urban communities. And it really has proven to us, our experience in the rural panhandle, that this is very much a reality. And we will continue to be committed to the region. And part of what we want to do in this webinar is to help spread the word about the science and art of making this all happen.
My name is Ty Cole, and I'm a research assistant for the Center for the Study and Promotion of Communities, Families, and Children. In this section, we are going to discuss what childhood trauma is, what it looks like in children who have experienced it, what the causes of trauma are for children, and then how does it affect them and the community that surrounds them. To understand the problem of trauma in children, we must first understand what it is and what it looks like. According to the American Psychiatric Association, trauma is a persistent psychological and emotional response to a deeply disturbing experience that has a significant negative effect on daily life. Trauma and stress-related disorders are a result from the childhood traumatic and stressful experience. In children, traumatic stress develops when children have been exposed to one or more traumas over the course of their lives and develop reactions that persist and affect their daily lives after the event has ended. Children who have been exposed to these traumatic and stressful experiences may be diagnosed with PTSD, also known as post-traumatic stress disorder, adjustment disorders, reactivity attachment disorders, unclassified and unspecified traumatic disorders, yet many children go undiagnosed. In order to understand trauma in children and its effects, Kaiser Permanente and the Center for Disease Control began to research the effects of adverse childhood experiences, also known as ACEs, in the mid-1990s. The research defined ACEs, these adverse childhood experiences, as traumatic events experienced by children before the age of 18. ACEs include all types of abuse and neglect, as well as parental mental illness, substance use, divorce, incarceration, and domestic violence. The study found a significant relationship between the number of ACEs a person experiences and the negative outcomes in adulthood, including poor physical and mental health, substance abuse, and risky behaviors. The more ACEs experience, the greater risk for the outcomes later in life. The adverse childhood experiences do not present the same in all children. The signs and impact of trauma can present as disruptions to healthy social, emotional, academic, and physical development, such as nightmares, reenacting of the experiences in play, regression in development, fear, detachment issues, and impulsive behaviors. These are some of those responses that children may experience. For children who have experienced trauma from birth to age 2 and are nonverbal, their symptoms may present differently. They may present as poor verbal skills, memory problems, excessive screaming or crying, poor appetite, low weight, or digestive problems. For children who range in age from age 3 to early adolescence, these symptoms may also present with difficulties focusing or learning in school, a learning disability, poor skill development, inappropriate behavior in social situations. They may also imitate the abusive or traumatic event. They may be verbally abusive. They may have trust issues where they are unable to trust others or make friends. they may take the blame for the traumatic event upon themselves, have low self-esteem or confidence, and have frequent stomach aches or headaches. Older teens who are going from age 14 to 18 might experience these in a different behavior manner, such as using drugs or alcohol, behaving in risky manners, and engaging in unhealthy sexual activity. The reason why children express their symptoms in a variety of ways is due to the effects of the trauma upon their brain development. While this continues to be a developing field of research, evidence from human growth and development models show that children develop their cognitive reasoning ability as they mature. In children that experience trauma, this developmental process is curtailed by their instincts for survival and to protect themselves, while their neocortex controls the cognitive abilities of children during the growth and development in children who have experienced trauma, and the reptilian brain becomes hypervigilant, and the lymphatic system, which regulates emotion, memory, or certain aspects of movement, becomes overstimulated. These heightened responses in the brain also affect the entire body. Stress hormones are increased, affecting the body's ability to fight off illnesses and infections. The increase in blood pressure and heart rate can affect the heart, while breathing and muscle tension can affect the child's nervous system. According to the ACEs study, the more adverse childhood experiences a child is exposed to, the greater risk that they are at for being diagnosed with cancer, heart disease, diabetes, stroke, and depression later in life. Now that we know a little bit more about what trauma is, what it looks like, and its effects, let us look at what some of the causes of trauma are. Typically, traumatic experiences for children fall into two categories: natural disasters and environmental experiences. Natural disasters could be earthquakes, extreme heat, floods, hurricanes, landslides, tornadoes, tsunamis, wildfires, windstorms, and winter storms. This 2018 map shows the $14 billion natural disasters that occurred in the United States in just that year, leaving communities devastated, children and their families exposed to trauma, and little to no existing support systems in their communities. Trauma can also come from environmental experiences. Environmental experiences are the things in a child's environment that could potentially cause trauma, such as family separations, physical, sexual, or psychological abuse and neglect. This includes trafficking. Natural and technological disasters, also disasters that come from terrorism. Family or community violence, the sudden or violent loss of a loved one. Military stress from deployment, parental loss or injury. Substance use disorders that are experienced within the child or within their family. Accidents and illnesses that occur to the child or a family member. And immigration with refugee and war experiences. As we discussed earlier, these traumatic events have a lasting impact upon the child that has experienced them, along with their support network, family system, and the community in which they interact with. When looking at these lasting effects, there is a secondary impact upon the meso and macro system that the child interacts with, such as the healthcare system and educational system. Resources are needed from these macro systems to care for the child and the impacted family system. Money, time, and community resources, which may already be strained from the traumatic event or disaster, often do not get allocated to support the child's recovery or support the family. So how common are these events? According to the Adverse Childhood Experience Study, 26% of children in the United States have experienced at least one adverse traumatic event. 16% have experienced at least two events, and 9.5% of children have experienced 3 events. The study goes on to say that 12.5% of children have experienced 4 or more of these events, which means that they are at greater risk for the negative outcomes in adulthood, including poor physical and mental health, substance abuse, and risky behaviors. These long-lasting negative outcomes will also affect the meso and macro systems that they interact with throughout adulthood, including the economy, which is negatively impacted by early death and debilitating illnesses.
Hello everyone, my name is Tisha Holmes and I will be talking to you today about the equity dimensions of vulnerability to disasters. Disasters disrupt the day-to-day functionings of communities, causing physical damage to people, infrastructure and property, business interruption. It also causes mental trauma, displacement during evacuation, economic losses, income losses, and closure of community facilities. And it may take years to return to normal, if at all. The pressures to recover quickly can lead to influxes of money and attention to disaster areas, which can leave certain groups out of the process or behind. Now, some populations or groups are more vulnerable to these impacts and effects than others. This can be due to their physical location, differences in income, race, age, gender, ethnicity, chronic pre-existing health issues, housing status, the housing type and quality, the immigration status, any physical, mental, and cognitive disabilities, their household status, and any other environmental or social stressors. And some populations also have less capacity to cope and recover from these impacts as well. Some groups may not have alternative sources of income or savings to cope. They may not have access to transportation or money to evacuate. They may not have access to insurance to rebuild or access to information to make an informed decision. Their social connections with others or community-based services or for support, shelter, and recovery assistance may be limited. They may have limited access to health care and insurance. They may not have access to quality and safe housing. They may not have access to quality community infrastructure and amenities. And there may be a general lack of representation in the decision-making process. And there may also be underlying existing health and mental conditions. Now, children is a special case as some of the most vulnerable to disasters. They may have significant developmental impacts, mental, cognitive, and physical trauma. They may be very susceptible to infection and disease. They may have a loss of family and community connections, a loss of sense of place and predictability. They are very vulnerable in temporary shelters, as well as the loss of schools, recreational spaces, and places of worship can have very disruptive impacts. In terms of reducing the distributional impacts and vulnerability, with a particular focus on children, efforts must be made at all stages of the disaster cycle. Prior to the disaster, surveillance is important, where you identify who is vulnerable and why. In terms of mitigation, we must focus on building codes, outreach and education, targeted drills and communications, improved infrastructure, and ensuring that households have an emergency response plan. There should also be attention to warnings, evacuation alternatives, and different forms of transportation, and ensuring that communities have survival kits. And then post-disaster, there must be opportunities to access funding, reestablishing community facilities and organizations, ensuring that the youth is mobilized, providing services such as play therapy, promoting relocation to safer places, and housing security. There must also be a focus on equity as an organizing principle in the inclusive recovery planning process. This can be achieved through groups such as community emergency response teams and community action teams. The community should also be engaged in the long-term visioning process, and community-based agreements should also be enforced. There must also be a focus on integrated collaboration and partnerships, where all agencies and organizations from planning, mental health, housing, emergency management, healthcare, and education come together to devise sustainable solutions with a focus on equity and the particular needs of vulnerable groups like children.
My name is Savannah Smith. I am the Program Associate for the Center for the Study and Promotion of Communities, Families, and Children. Today, I will be covering resources and interventions for children affected by disasters. As Dr. Holmes was saying, children and youth are one of the most vulnerable to the impacts of disasters. Taking in the fact that many regions will see an increase in the intensity and frequency of weather-related extreme events, steps must be taken to mitigate the profound impact that disasters have on children and youth, which influence their health and well-being throughout adulthood. It is crucial that we as adults and trusted supports in children's life are knowledgeable and proactive in accessing resources to help children cope with the stressors of a disaster, because they are very dependent on us to provide these resources to them. Resources targeted towards the 4 areas discussed, surveillance, mitigation, response, and recovery, must be utilized to respond and minimize the negative impacts. Links to access all the resources that I will mention will be on a slide at the very end of the webinar, and they are all free to the public. In the area of surveillance and mitigation, it is important to build schools, facilities, and houses that can better withstand disasters. One can build safer buildings by utilizing the Federal Emergency Management Agency Free Builder Guide. Emergency operation plans can be developed by accessing the Readiness and Emergency Management for Schools Center and ensure that all staff members are aware of the plans by practicing them routinely. It is also important to utilize developmentally appropriate curriculum to educate children and youth on disasters and give them basic preparedness skills. This can be done with an educational, exploratory perspective through play, activities, and reading. For reading to the children, one should utilize social emotional books. Social emotional books can help children think through emergency scenarios by seeing how characters respond and cope with an emergency situation. These books open up a conversation on scary situations for them to share their thoughts and feelings. You can access books from Scholastic, Forbes, or Save the Children and the American Library Association Reading to Ready book list to help introduce the topic of disasters. One should also utilize activity workbooks, web-based courses, disaster educational games, and multidisciplinary lessons. The Center for Disease Control offers great developmentally appropriate educational resources on all disasters. You can see that this is one of their activity workbooks called Coping After a Disaster. ReadyKids.gov also has many web-based courses, multidisciplinary lessons, and games for children and youth, as well as activity workbooks just like the CDC. You can see here their Disaster Master Game and Build a Kit game. Sesame Street has a website that offers an emergency preparation toolkit. It is also available as an app. On this website, they have many short videos that one can play in the classroom before beginning a lesson or at home for your children. Save the Children offers a disaster preparedness rally that uses engaging games and activities to bring various concepts to life, such as packing a go bag, making a plan, and identifying emergency contacts. Many times, children bring these workbooks home with them to complete or review with a caregiver, so this education reaches more than just the child. For example, with the Save the Children Prep Rally Know Your Number worksheet, many children do not know their emergency contact number and will have to wait to go home before filling this out. They also may not know or have an emergency evacuation plan, so they will go home and ask their parents about it, which will then spark that thought in the parent's mind of, oh, well, let's sit down and do this home mat worksheet together and make one. While preparation is essential in reducing the risk of long-term impacts, it is crucial to have effective and timely resources to intervene within the response and recovery phase. In the area of response, effort should be focused on meeting immediate needs and helping children understand what has happened. To meet immediate needs, provide evidence-informed psychological first aid. This is an evidence-informed approach for assisting children, youth, adults, and families in the immediate aftermath of a disaster. It is a 6-hour free training online on the National Child Traumatic Stress Network, and they also have a mobile phone app. It is a very interactive course that puts the participant in the role of a provider in a post-disaster scene. Core components consist of looking around the post-disaster scene and engaging with a person that you see in distress. You begin by providing them comfort and safety and help stabilizing them. You gather information on their situation, assist them with meeting their need, connecting them with social supports, and helping them learn coping skills that are specific to their need. And then you will link them with needed resources. After immediate needs are met, one should address intermediate and longer-term needs. One can do this by providing skills for psychological recovery. Skills for Psychological Recovery is an evidence-informed skill-building approach for assisting survivors gain skills to manage distress and cope with post-disaster stress and adversity. It is also a 6-hour free training online on the National Child Traumatic Stress Network. Core components include prioritizing the person's needs and concerns, helping them build problem-solving skills, promoting positive activities that they engage in that make them feel better, building their skills to cope, promoting helpful thoughts, and rebuilding their positive social connections. And all of these core components really work on introducing the skills that are necessary to improve their resiliency and coping mechanisms needed to facilitate recovery of function and to prevent those maladaptive behaviors that follow traumatic stress. Skills for Psychological Recovery places a greater emphasis on teaching specific skills to meet survivors' needs, as well as on following up to reinforce the use of those taught skills. In contrast, PFA is delivered in settings where follow-up may not be possible. Both PFA and SPR are forms of a crisis response. Therefore, an additional step is needed for treatment beyond this crisis phase. The recovery phase is this longer-term reconstruction and healing phase that encompasses treatment. It is very important to utilize evidence-based best practices to treat post-traumatic stress for children and youth post-disaster in a setting that addresses barriers to providing mental health treatment so that you ensure populations more at risk receive those needed services. Schools are ideal settings that significantly reduce barriers such as transportation, cost, and stigma. Children are already at school every day, so they're not having to travel to get these treatments. They also are not having to pay out of pocket, and offering these treatments in the school setting lowers that stigma on mental health treatment, which all of these barriers or reduce in barriers increase the likelihood of youth receiving the needed mental health treatment. Evidence-based best practices for treating childhood trauma in the school setting are known as Cognitive Behavioral Intervention for Trauma in Schools, CBITS, and Bounce Back. CBITS and Bounce Back aim to help children and youth process and cope with traumatic events, relieving symptoms of post-traumatic stress disorder, depression, anxiety, and behavioral problems to improve day-to-day functioning, grades, attendance, peer and parent support, and coping skills. This all aligns with the school's mission of children succeeding academically. Bounce Back is a modified version of CBITS so that it is developmentally appropriate for elementary age students. Both CBITS and Bounce Back include group sessions, individual sessions, and parent sessions. There are 10 group sessions, and these are focused on skill building. There are weekly letters and emails that are sent out to all parents and teachers so that they can provide support to the children for them to practice their skills outside of the group setting. The individual sessions are on an as-needed basis, and this is really for the children that need that one-on-one time to really process their traumatic experience. Parent sessions, there will be 1 to 3 group parent sessions, and this is where parents will be educated on trauma, the effects of it, and also tips on how to respond to your child if you do notice that they are having those impacts from trauma. It also informs the parents of the skills that the children are learning. So I really stress here just to find any evidence-based intervention that is proven to be successful in helping children and youth with post-traumatic symptoms, and to get trained in it now before a disaster occurs in the community. Out of all of these resources and interventions, FSU has followed and is continuing to follow this preparedness, response, and recovery model in our Disaster Rebound and Recovery Initiative with PFA, SPR, and CBITS and Bounce Back to respond to the impact of Hurricane Michael in coordination with Save the Children. We began by training social work students in PFA and Save the Children's Journey of Hope program, which is a form of SPR, Skills for Psychological Recovery, because Journey of Hope focused on strengthening their natural resiliency and giving them coping mechanisms to help them recover and process their emotions. We delivered Journey of Hope within the school setting. We then hosted a Save the Children preparedness rally with elementary students at a community center and began hosting Journey of Hope caregiver workshops. We realized the caregiver component is one that is very important and often looked over. Caregivers must tend to their own well-being to fully be present and attentive to a child's needs. We are now intensifying services by training students and staff in CBITS and Bounce Back to begin school-based groups in spring 2020. In these CBITS Bounce Back groups, children that need one-on-one time will receive individual trauma narrative sessions, and outside referrals will be made.
This is Ellen Piekalkiewicz, Director for the Center for the Study and Promotion of Communities, Families, and Children. A recent analysis by the U.S. Department of Health and Human Services found that 64% of the state emergency response plans do not adequately plan for behavioral health needs. Disaster recovery is generally planned and implemented at the local level. Emergency managers make use of pre-disaster drills with local hospitals to be prepared for physical injuries from disasters, yet few local governments have plans in place to address the short and long-term behavioral health recovery needs of their residents. The provision of mental health, substance use, stress management services to disaster survivors and responders is a critical component of disaster response. In the year after Hurricane Michael, it has been clear that vulnerable populations are experiencing significant gaps in mental health care. As you've already heard on this webinar, working with Save the Children, FSU was able to respond to serve children and their caregivers impacted by Hurricane Michael, but the needs are great and far outweigh the available resources. This graphic shows the interconnectedness of vulnerabilities, physical health, mental health, and ultimately community health. The loss of community health can lead to a loss of community cohesion and may lead to social instability and ultimately lead to long-term economic decline. A process for evaluating the needs for behavioral health care services and ensuring that those in need will receive timely and effective treatment is needed. One of the most frequent problems encountered in disaster and emergency situations is no mental health component is integrated into the health services network. An appropriate intervention entails involving the mental health component within the framework of comprehensive health services, without medicalizing human suffering, institutionalizing, or necessarily depending on specialist intervention. Disasters can become opportunities to strengthen behavioral health systems. Mental distress from disasters affects all restorative and rehabilitative efforts. Almost everyone in a community struck by disaster will feel some sort of emotional effect. For most, the acute reaction will be transient and functional recovery will occur. Through the collaboration with Save the Children, Florida State University was able to conduct 5 caregiver workshops in Hurricane Michael's impacted counties, in addition to services for children. The mental health needs of caregivers, first responders, and other emergency personnel must be factored in as communities plan for disasters. Mental health plan and recovery. What can we done to prepare? First of all, building awareness. That's what we're trying to do and what we're trying to accomplish with this webinar. And we are recommending 10 specific action items for the state of Florida and local governments to take. Action number 1. Every county should have a disaster mental health behavioral subject matter expert. This expert must be integrated into disaster planning and into exercises and drills. Action 2. Ensure interventions are developed based on identified needs and resources. Lack of funding for behavioral health care is a challenge, and during the blue sky planning times, the behavioral health care infrastructure must be addressed. Action 3. Develop public awareness regarding the mental health impact of disasters and community-wide emergency events. Action 4. Strengthen the capabilities of community members, including marginalized people, through self-help mechanisms and mutual support. Action 5. Ensure that disaster aid workers, community agents, response teams, including volunteers, and health services personnel are trained in and offer psychological first aid to victims and to all those who are in acute stress after exposure to extreme stressors. Localities need to promote a sense of safety, connectedness, calming, hope, and efficacy at the individual, family, and community level. Vulnerability in many populations stems from barriers to their access to behavioral health services, such as inadequate financing, lack of healthcare coverage, language impediments, and difficulties arranging for transportation or daycare. Bridging the language and cultural barriers of different minority groups is a special challenge for successful planning, response, and recovery efforts. Communities need to maximize the participation of the locally affected population in recovery planning in respect to behavioral health care. Action number 6, ensure that frontline health teams have the ability to identify and address the most common psychosocial and mental health problems, and that specialized services are strengthened and brought closer to the community. Action 7, minimize harm related to alcohol and drugs. Health promotion and protection actions that are carried out as part of the response to emergencies are important for people who engage in hazardous and harmful use of psychoactive substances. Action 8, as part of disaster preparedness or early recovery, initiate plans to develop a sustainable community mental health system. Early recovery efforts after a disaster create opportunities for the undertaking of programs and initiatives to promote development and prepare the community for future disasters. Constructing a sustainable community mental health system can improve resilience in the face of adverse situations and help establish better quality health care. Action 9, ensure priority is given to the psychosocial support, especially vulnerable groups, such as responders who worked on emergencies, 2, older adults, people with disabilities, 4, persons with severe mental illnesses, 5, people living in extreme poverty, and children. Action 10, integrate behavioral health activities and programming into other sectors such as education, healthcare, social services to reduce standalone services, reach more people, foster resilience and sustainability, and reduce stigma. Behavioral health care cannot be siloed. There are federal and Red Cross resources dedicated to disaster mental health services, but these services mostly are available immediately post-disaster and operate in response to crisis mental health needs. The state and county plans must account for these resources and find a way to capitalize on the resources. Hurricane Michael has shown that long-term behavioral health care is needed. Mental health planning for the future in Florida. Florida has appointed Darcy Abbott as the first disaster recovery mental health coordinator, whose job it will be to assist the state and local communities in developing a behavioral disaster plan. We recommend the state and every county develop a behavioral disaster plan with behavioral health care tools for disaster planning and response. A consensus be reached on required mental health training needs. State and local officials develop behavioral health public messages for their community. Florida State University is ready to assist the state of Florida and the Division of Emergency Management Services and local communities in developing a community disaster behavioral toolkit and other necessary resources. I will just close in reading a quote from the Surgeon General from 1999. Mental health is indispensable to personal well-being, family, and interpersonal relationships, and the ability to contribute to community or society. For more information, please feel free to contact Ellen Piekolkiewicz. We have curated a list of resources on the next slide to assist you.